I would like to thank the organizers for inviting me to present this talk on pediatric and adolescent headaches. Sorry I can't be there either virtually or in person with you as other conflicts came in the way, but hopefully this will be a very interesting half hour to 45 minutes or so of content for you to better understand pediatric and adolescent headache. Just to release some of my disclosures, I actually support a lot of different grants, the Research Foundation, as well as involved in as an advisory board to several different pharmaceutical companies. None of that will be really directly relevant to what I'm talking about today, although we'll quote a few of the studies that were supported by some of the NIH grants. So my objectives today are really to discuss what do you do for a child, how do you evaluate and treat them if they present with migraine in the pediatric and adolescent age range. Describing how that presentation comes about and the variability as it changes with age, and then maybe gain a little bit of understanding about the treatment and when to worry about when treatments need to be changed or altered. For the evaluation treatment, some special considerations need to be taken into case, including that the brain is actively developing through childhood and adolescence. So the assessment has to be appropriately gauged for the age of the child. In addition, the presentation of the symptoms may vary, which oftentimes leads to episodic disorders that may be related to migraine that aren't specifically labeled a migraine. Before we go on, I do need to make a clarity for a lot of people, as there is a lot of confusion. And one of that is that the disease itself is migraine. The symptoms are the episodic attacks, whether they're headaches or other attacks. Oftentimes people label the individual attacks as the migraine, and that's not the case. And the reason for that is, we'll get into a little bit, is that migraine really is a disease, and it's a genetic disease that's inherited. And therefore, the presentation of the attacks, whether it's the headaches or other events, is what we're trying to alter, as we cannot currently alter the genetic makeup. So I want to start a little bit with the discussion of the developing brain. On the left panel there, it shows how the brain, starting with age 5, going up to age 20, is changing in terms of its development and myelination. You don't need to understand exactly what's going on, but the key to this point, as you can see, it's a very active dynamic process. On the right panel, then you see 3 different views of the brain, from the right side of the brain itself, the left side, you then see from the top and also from the bottom. And these are movies that are running through a cycle, and they're all running sequentially in the same sort of pattern. And you can see how things move from the back to the front as far as that blue, which is the maturation. So full blue brain is a mature brain, whereas the yellow and red are more immature. Why is this important? Well, if we look at this next slide, which really just demonstrates the same thing, but more in a graphical presentation about what's going on. So starting with conception to birth, the brain is really forming, but even 2 months before birth, some of these developmental processes have begun. In the green lines there, it talks about the anatomical changes that are occurring, which include myelination, which is simply the insulation that's going on in the brain, with the final stages of development of prefrontal cortex. For this talk in particular, what's really more important is above that. So you can see that the seeing and hearing, which in the case of headaches, maybe the light or sound sensitivity, develops early on, as the visual cortex and auditory cortexes are the first parts to develop. Language follows shortly thereafter, and again, the initial stages of this is all in months before we spread into years. But the higher cognitive functions, the ability to express what's going on, feel the emotional as well as the cognitive states, really is developed in childhood and the teen years. Layered upon that is the effects of what the experience or the environment has. So the earlier we can intervene in a child or an adolescent that has headaches or starting to have problems with headaches, the sooner that the adaptation or modification can occur. What this is really representing here is then the ability of the brain to change. So taking that last graph, extending it even further as we go into adulthood and even older adulthood, we can see that although the brain can still adapt even when we're 70, it takes a lot more effort to do that. So childhood brains are not only more plastic, they have the ability to change, but the effort to make that change is easier. So the brain is developing as we go through this process, and trying to intervene as an early stage by recognition of what's going on and treating it is essential to make things better. So how do things start to present? I'm going to go through the criteria for migraine in a bit, but even before that, oftentimes children will present with what have been termed migraine variants, or changes that occur prior to the headache even starting. This is a very old article. The reason I always bring this up is Dr. Prinsky was one of my mentors, actually got me started in this area. And he, in 1976, wrote an article that really discussed what the different variants are that eventually lead to having migraine, including abdominal syndromes. But includes the abdominal pain disorders, which I'll go to in the next couple of slides in more detail. But these are oftentimes kids that are presenting with recurrent stomach pains, but yet to describe that they have a headache. And oftentimes these episodic or recurrent events are one of the first precursors or ideas that the genetic predisposition of having migraine is presenting itself. The graph below just shows how similar these early abdominal symptoms are related in terms of its presentation to migraine. Who really took this to the next level was Dr. Lanzi. Dr. Lanzi studied these, what we used to call periodic syndromes, are now changing to call episodic syndromes, for nearly 40 years. Unfortunately passed away about 10 years ago, but this sort of summarizes a large part of his life's work. What I wanted to show and draw your attention to is on the left is the graphic of the same table on the right. And in the second column of data is migraine. And if you compare that to the healthy controls, as well as those with psychosomatic disorders or other chronic pathologies, you can see that within migraine, a lot of these other episodic symptoms or symptoms that come and go are highly present, including recurrent vomiting symptoms, abdominal pain or recurrent abdominal pain, motion sickness or car sickness, as well as other pain disorders, including limb pain or vertigo, changes in fevers. We call it hypothermia, but it's really episodic fevers for no other explanation. And then there's some lesser rare variants, including torticollis. Sleep disorders actually raises to the largest number. This includes things like sleepwalking, sleep talking, and night terrors, which are all seen more frequent in children that eventually have migraine. The key component here is that all of these are episodic. They don't occur all the time. They don't occur continuously, but they come and go, typically at random, unpredictable episodes. So what I did is try to take this out and show how these sort of change through the lifetime and on many of these other graphs you're going to see, start with the all in years at the bottom, starting with age 1, going to age 16. So if we look at just the complaint of abdominal pain, and this is a compilation of multiple different epidemiology studies, so not all the references are included. But what we can see here is that abdominal pain is oftentimes a very common complaint in young children, the 2 to 3-year-olds. When it starts to become recurrent, that's what RAP stands for, is recurrent abdominal pain, it's much less frequent, less than 10%. Then there is a disorder that's been termed abdominal migraine, which is basically all the features of migraine but without the headache. And you start to see this in the 3 to 4-year-olds. The next graph actually takes away the abdominal pain to look at these more episodic or recurrent symptoms. And you can sort of see both in girls, which are in green, and boys, which are in blue, that there's really a strong peak for these abdominal type migraine symptoms that occur between the ages of 3 to 6 and then start declining. And it can occur up to 10% of children that age. There is a different disorder called cyclic vomiting syndrome, which is a very predictable episode of vomiting, typically almost clockwork time scale. The child might just have a day of vomiting every 21 days, and then it's completely normal. This is probably something completely different. There's a group of researchers we're collaborating with to try to sort this one out. Next, if you start to overlay what happens with migraine, what you can see in the orange bar, and the rest of the data is the same as the previous slide, is you can start to see that as abdominal migraine symptoms go away, the presentation of migraine goes up. Now, what's the explanation for this? Well, most frequently and anecdotally, the explanation is that for these kids with recurrent abdominal pain or recurrent abdominal pain with additional symptoms that are suggestive of migraine, no one bothers asking them if their head hurts. And once they start complaining that their head pain is in there with the other symptoms of nausea or vomiting, then it becomes migraine. And so what is really happening or evolving is these children are better able to express what's going on, or someone asks them, does your head hurt at the same time? So there's a clear awareness needed. So what does this relate to development? Well, if we go back to, and the reason I discussed the development is that really those higher cognitive function abilities that start to develop in the early childhood to early adolescence is really overlaid about when the increase of migraine occurs. So it may simply be that the child is not able to express the symptoms and express what's going on and needs some prompting to ask for what's going on. I did want to show that there is starting to be a separation of boys and girls. And so there's in addition in the experience-dependent synapse formation is that as girls and boys go through puberty, there's different hormonal effects. It's outside the realm of this talk, but as you can see, as girls go through puberty, the frequency of having migraine goes up. So when you do the assessment, that means you have to choose age-appropriate assessments. So thinking, it starts out with, again, the child is the one that has to express what's going on. I've said several times that you have to ask the child, does your head hurt? Parents who have headaches and therefore have especially frequency, they just think they're just headaches and not recognize that the child is having migraine, or in some degree of denial of assuming that their child does not have the same disease they have. When you do this assessment, then you really need to focus on what the kids are feeling that's going on. And so asking the child, and as a parent yourself, it's hard to step back a little bit, but kids are actually very good about being able to answer things. Now, part of this is limited by the developing brain. They may not be able to put things as in words. So having them describe either visually what's going on, or oftentimes using additional tools like drawings or acting things out can oftentimes be useful. The other things that are important to consideration is that children in general are healthy. Now there are kids, and I know in this session we're talking about children that oftentimes have charge, so they do have additional associated components, but children themselves are less likely to have both a comorbid illness that can influence it, or a sort of anchoring bias that they're relating their headaches to other diseases, whether it's asthma, allergies, or some anxiety or depression that can occur with that. In addition, the episodic role of these symptoms makes it all difficult because between episodes, the kids feel fine. Furthermore, though, as kids start to enter school, they will have additional disabilities, and taking into account their inclusion in school and how they can interact both not in school, but also with social and home activities is an important part of the assessment. So moving on just specifically to migraine, and many of the features for episodic disorders or periodic disorders sort of overlay this because they have common and overlapping features. So I'm going through the criteria to start with. We are currently on our third edition of the International Classification of Headache Disorders. I was actually the pediatric and adolescent chair for this section. And so we did make some adaptations for children and adolescents, but as we've gone through the editions, we realized we needed fewer and fewer adaptations because, again, it's a disease, migraine, and they're just kids that happen to be younger than the adults. So in this classification scheme, we really divide headache types into either primary headache disorders or secondary headache disorders. Primary headache disorders are diseases in of themselves. So this includes the migraine, tension type headaches, something we're not going to talk about called trigeminal autonomic encephalopathy. And then where we have other primary headache disorders is sometimes where we include some of these features that aren't quite to the level of migraine, but maybe something else, such as probable migraine. Conversely, secondary headache disorders are headaches that are caused or attributed to something else. So there should be a direct cause and a effect. Oftentimes, and probably one of the most common misleading directions that this happens is sinus headaches. So a lot of people, in fact, 90% of people who think they have sinus headaches don't, and this has been demonstrated by 3 fairly large studies. The largest was 4,000 adults in Southwest Missouri, all of whom had thought they had sinus headaches, but when they came in to be evaluated by a standardized approach, 90% of them actually had migraine. This was such a marked number, it was repeated in Rome, as well as Brazil and Southeast Asia, and all three other places found very similar results. So one of the keys to this is that people have lots of allergies and sinus problems, so they oftentimes try to blame their headaches on something else. But once you treat the sinus disease, if they have sinus disease, and the headaches continue, then they lack that cause-effect relationship. The other secondary headache disorder that oftentimes gets confusing in children and adolescents is the presence of head trauma. Now, kids bump their heads all the time. In fact, in our survey of our database that we can track all our patients, at least 10% of them or more can recount a significant head injury of which they've hit their head and they can recall it. The key component that's becoming clear with head trauma and post-traumatic headaches is that it appears that only people that are genetically prone to headaches in the first place, in other words, have the gene for migraine, are those that tend to have significant headaches after head trauma. So kids can bump their heads a lot, but those that have episodic headaches, they may worsen once they get a head trauma. So it's not really a cause or effect, but maybe a triggering or worsening component. And then the third one I'll talk about later on here is the overuse of medications and the withdrawal effect we have to be careful about. There is a third category at the very bottom, and those are mainly to exclude other, we call neuropathies, which are disorders of the nerves themselves. Very rarely seen at all in children, sometimes seen in adults, especially trigeminal, temporomandibular joint disorder. Many of you as adults may have this or have had that, but that's where the joint itself can trigger off a headache, and sometimes that can irritate the trigeminal nerve, which can also contribute to a neuropathic pain. So focusing in just on migraine, from a research perspective, we can actually get very deep into how we diagnose things. So at the largest level, we just call it migraine. Sometimes they can not have auras, or they can have auras, so we can add a second digit to define that. And sometimes the auras are typical, other times they're not. So we can add a third digit to that. And some people have aura without headache, and one that is not included here is we even go to a fifth digit now when the very specific gene that's causing it has been identified. If we look at migraine, then how can we break it down? So we can break it down in a variety of different types. So the most common feature we see is migraine without aura. And I'm going to go through this classification in more detail in the next few slides. But in addition to that, there's what we call migraine with aura. Now, what an aura is a warning sign that you're going to get a headache. These are typically 90% of the time tend to be visual, and it has to have a positive symptom. So many people will say they have trouble focusing their vision during a headache attack. That doesn't count as an aura. What counts as an aura for the roughly 10% of you in the audience that has them is you'll see flashing lights or wiggly lines or star-like patterns that may start anywhere from 5 to 60 minutes before the headache starts. About 30% of people get a sensory aura, where they have tingling, typically starting in one hand, that'll move up to the face and cause their arm to go numb, and therefore make it difficult to use, although they can still use it. And then about 10% of people have something we call a dysphasic aura, where they have trouble talking during the aura phase. So recognizing that this is going on as an aura is important, because oftentimes kids will get labeled as having a confusional period, when in fact they're not confused, they just can't exactly describe what's going on. There are also things called chronic migraine, which is just a very frequent occurrence of episodic attacks over half the month. There are some rare complications, which I'm not going to go into this order. Things called probable migraine, which meet almost all the features, but not all of them. And then the early presentation of symptoms that I discussed already, we call episodic syndromes associated with migraine, but includes the GI or gastrointestinal disorders, including abdominal migraine. But there can also be episodes where children in particular are more likely to have this of episodes of vertigo, where they have a headache that's also associated with that spinning feeling. It's clear spinning and not just lightheadedness, or they may have twisting of their neck. This is oftentimes in the 6 to 12 months age, where a child may be crawling, and for 15 to 30 minutes, their head will look like it's twisted to the side. And this is something we call paroxysmal torticollis. If we look specifically at the criteria for migraine, and I know this is a lot of detail, but I think understanding the variety of this is important. You need to have at least 5 attacks. This reflects the episodic nature. Now, it's 5 attacks over the past year. So even one every couple months is enough to qualify. Typically, the attacks will last 4 to 72 hours if untreated. We do make one exception for children. We lower it to 2 to 72 hours. We used to lower it to 1 hour, but there's really no evidence that untreated headaches for children are consistently that low. They may have short headaches at times, but if we ask, do they have enough headaches that fit within this time period, we usually are consistently able to get that 2 to 72 hours of untreated headaches. Now, one key point I did put in red here is that sleep is included as part of the duration. So if a child goes to sleep with a headache, it's not just the half hour it takes them to fall asleep. The duration of the headache is determined until they wake up headache-free. So if they sleep overnight for a headache, that really can be a 10-hour headache, the way we count the duration, because we're never quite sure when it goes away during the sleep period. The headache itself has to have 2 or 4 characteristics. We usually expect it to be unilateral in location or one-sided. In fact, for the people that are interested in history, the term migraine actually comes from Arterius of Cappadocia, who described it in 200 AD as a half-sided headache. And that's what migraine means, which is where the term migraine came from. It should be pulsating in quality, so a throbbing or pounding location. Now, kids may describe this more as somebody beating on their head. It can be moderate. It doesn't have to be severe, and this is oftentimes one of the big mistakes that a lot of people think of the attacks of migraine have to be severe, when in fact more people have a medium headache pain severity. And then it should be aggravated by routine physical activity. In other words, trying to move around, or in kids' case, trying to run, play, things like that, stop them because it makes the headache worse. It also then is associated with specific associated symptoms. So from the episodic disorders, this is where the nausea and the vomiting oftentimes comes in. So for a child that complains of a moderate headache that's throbbing and they throw up, that's enough to qualify as a migraine. Now, if they don't have that pain, but they have an episodic disorder with the other features, that's what we call an abdominal migraine. Photophobia and phonophobia is harder to discern in younger children. It seems to develop more as children go through adolescence. Conversely, the nausea and the vomiting seem to start to diminish. And then we always have a catch-all phrase not attributed to other headache disorders. So for children and adolescents, our criteria do allow for some acceptances of variations. First and foremost is that we do recognize that children may have shorter headaches, and so we reduce the duration to 2 to 72 hours. Also, it's been recognized that children are more likely to be bilateral. In other words, their headache may occur on both sides of their head, typically in the temporal region, or in young children, they oftentimes point to the front of their head. In addition, light and sound sensitivity may be inferred. In other words, the child may deny that the lights and sounds bother them, but the parents say, well, then why do you go to a dark room and tell everyone to be quiet? And that really can be counted as the light and sound sensitivity. Other than that, there was no other specific criteria changes for children, recognizing the fact this is a disease and children just happen to be in the age range where the disease is presenting. So one of the tools we can oftentimes use for, and I'm going to have a little fun here showing you some of these drawings that our kids make. We ask the kids to draw what it feels like when they have their headaches, and that oftentimes can give us some insight into what's going on. So I've used a few examples here. This is a 4-year-old, and it's appropriate for a 4-year-old where most of what they draw is their head. Be able to recognize this is their nose, this is their mouth, these are 2 eyes, but most importantly, they're pointing where their head hurts, right there in the front. So this girl is giving us our location for her headache by the drawing, even if she can't tell us. A little bit older girl, so this is a 6-year-old girl. What you can clearly see here, even though she may not express it, that the light bothers her. So she's crossing out the sun or trying to block out the sun. And she's got a throbbing or pounding quality to her headache. Additionally, she's not very happy. So she draws her face as a frowny face. So just from this drawing alone, you can induce the throbbing quality, the photophobia, and that it's altering her sort of activity or functional level. A little bit older girl. So this girl is actually using some words to describe as she's developing into sort of a language component. I've written the text out for you here, but it's really just says, when I have a headache, I bug my mom for Motrin almost every day. And we're going to discuss about that a little bit further, about potential risk factors that can make the headaches worse. And one of them is overuse of medication. I like this one for this boy. He just decided to draw a key, but the takeaway I'd like you to see is that he does direct that everything is happening inside his brain. So this is really a neurological disorder, and he's recognizing this at age 8. Many adults aren't recognizing it. So the idea that he's shown his brain's being attacked in multiple different ways, I think is a very insightful component that this boy brought out. Keep moving up in the age. Here's a 12-year-old. I like this drawing more because she has lots, and I'll let you read some of those yourself, but has lots of different components that she relates to, including where the location is, her light and sound sensitivity, that the location may vary and the pain quality may vary from time to time. A little bit older girl. This shows how kids are trying to cope as well as they can. A big smile on her face where she says she's sad but still happy, meaning that she's trying to get along. She shows the stomp, the throbbing quality, how her head feels. But I've also written what she said here is how she feels aggravated, but she doesn't want to hurt any people, so she's going to throw cotton balls at people. So she really wants to be left alone, but still doesn't want to hurt anybody. And then finally, just a very dramatic drawing of an 18-year-old. It's dramatic, but I think it really highlights the overall impact that a headache attack is having on this young person's life. So how do headaches change throughout the ages? So using these criteria, we can actually look at a variety of different features. I previously already shown the sort of epidemiology or the sort of the ages that headaches occur across the age period that do increase fairly dramatically during puberty. On the right panel, though, it shows our experience of how long it takes from when the family first notices the child is having a headache to the time they're referred for evaluation. And what we can see is that as the child gets older, it takes longer and longer, more and more years to come in here. So if we're trying to intervene with a changing brain, the earlier we can recognize that this is a problem, and the earlier we can intervene, the more likely we can improve the overall outcome. And then the final right slide actually just shows the breakdown between boys and girls as a percentage of what we start to see. Moving on beyond what we see, it is a worldwide disease. So in every 5 years, the World Health Organization looks at the global burden of disease. It takes them a while to analyze it. So this is from 2015 data. And this looks at the top 10 diseases across all the age ranges. So starting from the early neonatal period all the way up to greater than 80. Those in green are ones that made improvement on, so they've actually been diminishing. So it's nice to see iron deficiency in the world, especially in third world countries, has gone down. But those in red are those that are actually seem to be more impactful, getting worse. To make it easier to focus, I've actually blocked out everything except where migraine falls. And you can see that migraine really is starting about age 10, enters the top 10 diseases across the world. And in the most productive years, it's actually the third most common disease after depression, as well as back and neck pain. So 2 pain disorders and a mental health condition actually are the top 3 disorders throughout the most productive years. Now, as women go through menopause, their frequency of headaches starts to decrease. And so as women and men to a lesser extent start to age, then the presence of migraine starts to get replaced by other chronic health conditions. If we look at just neurological conditions, so taking that same and just focusing on neurological conditions, we can see worldwide in the very early period, there's quite a few problems with children having infectious disease processes. The gray bar, the brown bar, and the teal or light blue bar are all neurological infections. And you can see they make up a large extent. If you eliminate those components, you can see that there's a steady rise of neurological conditions. I'm going to focus in a little bit more just so you can see better. But if we look across the ages, the blue is actually migraine. The orange is another headache disorder, tension type headache disorders. Red is overuse of pain medications and headaches. So if you stack all three of those, what you can really see is, excluding again the infectious diseases, that really in the 10 to 15 age range, headaches, in particular migraine, become the #1 neurological condition and continue that way until the start to be influence of disorders of dementia and aging that start to take over as neurological conditions. So if we're really talking early educational and productive years, migraine makes a large impact. If we look at particular features and what we see in our children that come to the Cincinnati Children's Headache Center, we can see that many of them are actually having quite a few headaches, even down to a 4-year-old. They're having at least 2 headaches a week. Some of the kids that are in their teens are having headaches on average more than half the month. We look at all the features of the criteria I talked about. Many of the kids do report that activity worsens their headaches. But if we look, which is in the upper left panel, if we look at the location in the lower left panel, we can see that bifrontal location slowly gets replaced with first the bitemporal, and then the unitemporal or right-sided starts to build up. If we look at the associated symptoms, which is in the upper right panel, we can see that the light and sound sensitivity actually are starting to be recognized early on. That's the red and the green lines there. Whereas the nausea is persistent but starts to diminish in the teen years. And the vomiting, which is in orange, which is not as prevalent, really starts to go down. Although it's still persistent, 30% of the kids as they go through their late teens. One of the criteria, one of the components that is not as the criteria is lightheadedness, or that feeling that their head is floating. And that really starts to develop and progress through the teen years. What this is biologically their blood vessels are dilating, and so they get this lightheaded feeling or pre-syncopal feeling. So one of the episodic disorders that oftentimes occurs or co-occurs with migraines is pre-syncope or fainting spells during the headache attack. And this is oftentimes associated with that vascular dilation. If we look at the duration of the headaches, kids can get long headaches. Looking at this, if we ask them what their longest headaches are they have, some of these kids will get into multiple days worth of headaches, especially during the teen years. But even their shortest headaches will last several hours on average. So these headaches can last a long time. So relate what's going on, it's really correlates very much to what I said at the beginning, that the brain is developing, and as the brain develops, these characteristic features map nicely across those age ranges. So why do people have migraine? We now know that it's migraine or other episodic disorders related to migraine. Well, the first answer is it is genetic. So if we ask a family history, in the red bar here is the self-reported number of mothers with headaches, which reaches 75%. But the mothers also know they have migraine. So 70% of them actually report they have migraine. So clearly a high inheritance pattern. A little bit less on the father's side. Part of this is biological, as boys' headaches tend to get better as they go through puberty. They may have forgotten the fact that they have headaches or migraine. And there is a 3-to-1 ratio of the hormonal effects that occur during adolescence in adults, making the presentation of migraine, not the disease itself, because the genes are still there, but the presentation more likely in adolescent girls than adult women. I do want to mention a few studies because I think it helps understand these studies. You don't know a lot of the science or the details about it, but the emphasis that it makes. This is an old study, sort of pre-HIPAA, and in fact, I'm not even sure they still have HIPAA in Sweden, where they can actually look at birth records. So they were able to look at all children that were born 10 years before the study or 8 to 9 years before the study. At that point, we were on our first round of our criteria, and they looked at those children that were twins. Now, when you have twins, you can have what we call monozygotic, which are identical twins, meaning they have exactly the same genes. Or you can look at dizygotic, which are just like any other siblings. They share half the genes. And then, of course, they can be boys or they can be girls. So there's the hormonal influence. Or they can be opposite sex, which is what the US stands for. So they were able to gather and study out of these 1,480 Swedish twins. They will examine a little over 1,000 of them, looking at their twin pairs. Now, the reason this is important is they had a model in place. So in the middle here, there's T1, T2, those are each of the twins. The E is independent environment, meaning those environments that were not universally shared. The C is a shared environment, meaning things that they exactly shared. That's why it's got a weighting of 1. And then A is the genetic factor, which can be either 1 for monozygotic twins or identical twins, or 0.5 since they share half the genes in the dizygotic twins. And the bottom line from the study is shown in this table. I'm going to zoom in on that a little bit. Without knowing what all the details are, you can convert these estimates into a percentage. And what this really tells us is that 70% of the reason that these 8 to 9-year-olds had migraine was because of their independent genetic makeup. That's the A part of it. 0% was the shared environment, so it doesn't matter what they shared, but there was a 30% influence by a non-shared environmental effects that were, meaning that these were environmental effects that one twin and one pair might have and another twin and another pair had that influenced that. So 70% of the reason that they have migraine is because they've inherited the genes for migraine. 30% is because they have an environmental influence that's affecting them. Now, I'm not going to go through the gene studies in detail, but there have been some international projects that have gone on, and we're now up to 38 different genes that are associated with migraine. So it's something we call a polygenic disorder. It's not a one gene, one effect disorder, but multiple genes that may influence that expression and the degree of that component. And there's active research, including research we're doing here, to try to delineate exactly the influences of those different genetic components. What's happening during the brain during a migraine? Well, kids can tell us they don't feel right. Adults, the parents that have migraines, say it's harder to do things. So they can tell us that, but can we measure that? So we also did a study here, and again, this is another study, but it emphasizes the impact visually of what's going on. So we have a machine called a magnetic encephalogram machine. What this does is it measures the magnetic activity of our brain. Now, for all of you going back to high school physics, I know that can create a nightmare for many, but if you understand electricity and magnetism, our brain has a lot of electricity. That's how we signal things. And in a 90-degree angle to that, that creates a magnetic wave. So we can measure that magnetic wave, and that's what a magnetic encephalogram machine does. For this particular task, what we did is the children would be listening and hear a click in either their right ear or their left ear, and then have to respond. That's shown here. So an example, they'll hear a sound cue, which is a click. And then if that click comes in their right ear, they're expected to click their right hand or tap their right finger. If it occurs in their left ear, they're supposed to tap their left finger. So they have to localize it and then respond. What those wiggly lines are, and I'm actually going to show a blow up of that, and for different cases, you can see the trigger, which is the click, and then how long it takes for them to respond magnetically. So it's not when they actually their finger taps, but how long the signal in the brain creates that lead to a finger tap. So in other words, how long you're processing. And you can see that orange line, that MEF line or induced signal line, is basically twice as long for people during an acute migraine attack. So these people were having an attack of their headaches and trying to do this. So it took them twice as long to process that. We can see what's happening in the brain, though, because we can take this, the advantage of magnetic encephalograms, it also gives us anatomical location. So on the left there, both if we show just an example of a 12-year-old and a 16-year-old, you can see that during a headache-free period or during their normal period, it takes very little of their brain. You just see that little red dot there to complete the task. However, during the headache attack itself, you can see that the amount of involvement of the brain actually increases and becomes much more intense. That's why it's more yellow in color. On the right panel, though, you can also see not only does it become more intense, but they actually have to involve a lot more of their brain. So when kids tell us it's hard to think when they have a headache, they're right, because it's taking a lot more energy. It takes a lot more brain power, a lot more brain itself to be able to accomplish that task. So why is this important for us to all realize? And why am I asking you to think about this? Well, the children are in school. And if you're in school and you're trying to learn math or read a book or doing something that you're going to be tested on later, and you're requiring to use twice your brain power just to get through it, you're not going to do as well. So being able to recognize that children and adolescents are having migraine and stop it quickly allows them to function better in school and retain that essential knowledge that we're hoping that they gain. So how do we treat a headache? So we divide the treatment typically into both acute and preventative components. Now, I'm not going to go through specific treatments and advise you specific doses. That's the role of your primary care doctor to advise you and your child to do that. I'm going to talk about some philosophies of how to accomplish that. So acute treatment is what we do when a headache attack starts. So how do you stop the attack once it starts? Prevention, on the other hand, is how to prevent the headaches from starting in the first place. It can involve both pharmaceutical, healthy habits, and biobehavioral treatment. For acute treatment, there's a variety of different treatments available, but we've asked patients what they want. And this is for adults. And it's no surprise. Adults want the headache to go away, and they don't want it to come back. And they want it to happen as quick as possible without side effects. When we ask the kids the same questions, it's the same thing. So patients want them to go away. This is a very old review. It highlights a few of the different medications that are still commonly in use. But they include things like acetaminophen, which is Tylenol, ibuprofen. Many of you are probably using that for your own headaches because it's available over the counter. But there are migraine-specific medications also. And again, I'm not going to go through the details of these medications, but the more of just having the knowledge that there's a lot of different medications. Over the past year, there's actually been 2 entirely new classes added to this list. One's called GPANTs, which are derived based on the CGRP, which is a molecule that seems to be involved in migraine, and the other is something called Dietins, which is a variant of the triptans. So for those of you as adults that have headaches, if the typical things aren't working, there's a lot more varieties. These are now beginning to be looked at in adolescents and children. One caveat, though, with any sort of acute treatment is that if you overuse a good thing, it can make it worse. So medication overuse is defined as overusing a medication. So in a prescription medication, it means using it more than 10 times per month. In an over-the-counter medications, it's more than 15 times per month. But why is this important? So again, I'm going to refer to one of our studies, and this is one of our genetic studies, where we looked at kids with chronic headaches, so headaches more than half the month. And we looked at what happened for those that responded rapidly to treatment versus those that didn't. One branch of this arm were those kids that were overusing pain medicine. And so when they stopped overusing pain medicine, there was a change. And what that change was, is it looked at how they responded or didn't respond to treatment. So we defined responders as those that went from a headache almost every day to less than 10 headache days per month, and those that were non-responders that have continued headache days. The reason I'm showing this is the next slide. So you don't need to know what this is. This is a gene expression profile. But what this does is it breaks down those that didn't respond versus those that responded. Each of the lines there, which can be represented by the green line on the left, it represents an individual gene, and each of the top represents a patient. The way the program works, it clusters the patients, so those that are most alike are clustered together. The very bottom, and then in color, identifies the non-responders or responders. What you can see is they do cluster together. And so there are approximately 300 different genes that seem to be actively turned on when you overuse or take medication too frequently, that once you respond, these genes quiet back down. So by overtaking medicines, you're actually changing your genetic pattern in your brain. So you can change your brain through your treatments. What are the barriers to acute treatment? Well, first of all, people have to realize that currently we don't have anything that's 100%. So if the patient's expecting a 100% response, it'll be difficult to obtain. So there's variability between patients. There's also variability between headaches. This should be expected. As I said, it's a polygenic disorder. 38 different genes are responsible for this common phenotype. Oftentimes there's reliance on severity as a determination of medication, meaning that we can use something called multi-mechanism treatment. For little headaches, sports drinks alone may be useful. For moderate headaches, you may need to add an NSAID like ibuprofen. But for those really bad headaches, if the NSAID and the sports drinks together don't work, you sometimes have to add a migraine-specific medication. So ranking the severity and treating early can be important. And then you also have to be careful of too much of a good thing. So what are the goals of acute treatment? Well, the goals we set is the headache is gone within an hour and the patient is back to normal. So back to normal means they can completely function. That's why we never mention or should never mention narcotic medications or sedative medications. Because even though you may not feel like you have the pain after you take a narcotic, you're not back to normal. So you need to return to normal as well as bring the headache on. Strategies to use is you need to use an appropriate medication. You need to use an appropriate dose that's based on the child's weight. You need to take at the onset, because the earlier you take it, the earlier it's gone. And then make sure and stress that you shouldn't overuse the medication or use the medication too much. As that one girl's drawing said, she was asking for the Motrin every day from her mom. Giving it to her every day would be the wrong thing. What happens if kids are having frequent headaches or disabling headaches? Well, then we sometimes consider preventive treatments. So preventing treatments is if a child or an adult has more than 1 to 2 headaches per week or significant disability due to their headaches, it should be considered. The goal is to get people down to less than 1 headache a week without disability. Most patients will say if they're having less than 1 headache a week, they can go away in an hour, they're happy with that. Medication has to be specific that are disease specific. And one of the newest things we've discovered is once the goal is reached, you can stop the pharmaceutical treatment. You don't have to continue people on it forever. Often people use nutraceuticals. I'm not going to go through the details of this, but there have been some that have specifically been identified as being low in patients with migraine. Folate is one of those that comes from green vegetables, especially in adults with aura. It's been identified as low. We've also identified that coenzyme Q10, riboflavin, and vitamin D can all be low in a large number of children and adolescents with frequent headaches. So our approach to nutraceuticals is let's use science and identify what medicines and what vitamins are important and identify who is low and supplement it rather than automatically give it to everybody. Behavioral treatments are also very important. This is what people do the rest of their life to keep themselves healthy. So we stress 4 behavioral components. One is making sure they get enough to drink every day. We usually recommend at least 8 to 10 glasses of fluid, typically water. We do avoid caffeine. Exercise is important, and usually it's a minimum at least 4 times a week. And this is a lifelong pattern we should develop for at least 45 minutes. Not only does that help our brain overall health through generating a growth factor called BDNF, but it also increases the CGRP, so may directly influence the impact of the headaches and the migraine disease. The 2 other healthy habits, and the reason I clicked on this slide, one is making sure you get enough sleep on a regular basis. Patients oftentimes recognize this because they go to bed, but regular sleep is important ever on a day-to-day basis. Not getting enough sleep, and even more important, getting irregular sleep, meaning an irregular bedtime and a wake-up time, can trigger off headaches. And then the final healthy habit is make sure you get enough sleep or get enough to eat on a regular basis, meaning avoid skipping meals. Patients recognize this and they try to control their diet in such a way. So the 4 healthy habits we talk about, again, are increase their fluid intake, get a regular sleep, eat healthy, which may be also augmented by checking their nutrition, their vitamin levels, and then the regular exercise. For kids that are having a lot of difficulty and struggling with their headaches, especially in chronic migraine or more frequent headaches, we can use something we call coping skills or cognitive behavioral therapy. In the next few, and coming toward the end here, but the next few slides that I'm going to discuss, talk about cognitive behavioral therapy and the studies we've done with it. So cognitive behavioral therapy, or as I describe it to kids, it's using your own brain power to control your behavioral response to pain, has been studied. And we've actually looked how effective it is in combination with one of the preventative medications we use, amitriptyline, for children and adolescents with very frequent headaches. What we look at is that really the combination, so the bigger the bar, the better, not only improve the kids after 20 weeks, but even 12 months later, the kids were still doing much better if they learned cognitive behavioral therapy or learning how to use skills to address their headaches. Cognitive behavioral therapy usually takes about 6 weeks to learn. It's a once-a-week session for 6 weeks. But as I told the kids also, once you've learned it, you don't need a refill, and there's no side effects. So it really is something to incorporate with it. One of the other reasons I brought this up is to look at what we call the trajectory response. And this is one of our newest findings that we've been able to identify and why we say that kids can go off their medicines, as can adults, once they're under good control. So we looked at how quickly people responded. That's just represented graphically here. So all these kids go through a baseline period, which means for 28 days, they just keep track of their diaries. They try to maintain healthy habits, use a proper treatment. And what we can see, their chance of having a headache really didn't change. Once they began treatment, we saw that the actual treatment started to occur very rapidly. This graph doesn't show it quite as clearly, but on our next group of research studies we did, called our CHAMP study, we were able to dig into this in more detail, and that's shown here. And we actually identified that the graphs, whether we use the different medication treatments that we used in this study, which include amitriptyline, topiramate, or even placebo, what we were able to see that was in about 8 to 10 weeks, the maximum slope of the slot occurred. So for those kids, they're going to see their benefit. It's going to happen fairly quickly in the first 2 to 3 months. Now, in some kids, all the second slopes and all those show there was some continued improvement. So for those people that haven't reached their final goals, continue the treatment may be necessary. Conversely, those that have reached their final goals can go off the medication. Well, why do all these studies confusing, and why do we not talk about medications? Well, there's one big area in all pain disorders, and in particular headaches, that also needs to be included, and that's called the expectation of response. So if somebody expects they're going to get better, they will get better. But why is this? Well, this comes out of the pain literature, and what we're really looking at is the global impression of change. To help see this better, I'm going to expand this. But if the patient, which on the left side, they expect pain relief, they expect improvement of their quality of life, and they expect improvement in function, the numbers or the weighting here influences how their overall disease changes. And if they expect the medicines to work, so they expect pain relief, then their likelihood of the global impression of change, or the likelihood that they get better, goes way up. And it can affect multiple different factors. It can affect the pain intensity, so how bad the headaches are. It can affect associated symptoms, such as depressive or anxiety symptoms. It can affect how pain interferes with their life. It can affect how they view the pain itself. Do they catastrophize, or they feel like, oh no, I can't go to school today because I'm afraid I'm going to get a headache. If they know they have a successful medicine that works, then that pain catastrophizing can go away. And if they can tolerate the medicine without side effects or problems, there's also additional influence. So if they believe that the acute medication, the preventative medication, and the healthy habits, they work, so they expect things to work, then things will get better. So where do we go from here? Well, we still have a lot of work to do in children and adolescents with migraine. Many of the research studies have been limited to adolescents, and we're now moving on to the 5 to 11-year-olds for a lot of the new treatments. Our goals are to get kids down to 1 week per less, so that's what we focus on in a lot of the research we do. And we have identified the benefits of multidisciplinary care that can help integrate that cognitive behavioral therapy at the very beginning. It may not be that the medication itself is the cause for the improvement, just the expectation. So the optimistic expectation they're going to get better can always help things out. And what do we do with the 30% or so kids that don't get better? And that's where an area of research and studies we have a large focus on. As parents, when do you need to worry? Well, the first stage of worrying, if your child starts to have notable headaches, it means it's not normal to complain of headaches. If your child's complaining of headaches, even if it's once a month, discuss this with your primary health care provider. At the very minimum, they can discuss early onset of treatment and send you a school note so the child can take their acute medications as well as drink lots of water during the school day to help with their headache resolution and prevention. If the headaches start to become more frequent, so 1 headache per week or more is our usual recommended cutoff, and the acute therapy doesn't seem to work quite as well, you need to re-see your physician or primary healthcare provider and talk about adjusting your acute medication, potentially adding a migraine-specific acute medication, and even consider prevention. If you tried these goals and things aren't working, then seeing a headache specialist or a neurologist may be the next sort of step on your pathway. There are some caveats on when to image a child. We recommend the international standard is that all children 6 and under should be imaged. That's partly because, again, that goes back to that developing brain. If the child's not adequately able to describe what's going on, there may be something or a red flag that we are not able to identify. The most frequent red flag, though, for identifying that a MRI or an imaging study needs to be done is if there's an abnormal neurological exam. So if the child's not moving an arm or a leg, or there's something just a little bit unusual, especially during the exam, then just being safe and making sure everything's is necessary. Saying all that, about 10% of people will have abnormalities that are incidental and non-consequential. So even if an MRI comes back with abnormalities, the most common being something called gliosis or scarring, is not something to worry about and may not be cause for the headaches. But there are some caveats of So finally, putting it all together, what do we need to do? So patients and parents oftentimes present because the headaches are impacting their lives and something needs to be done. Using the combination of acute treatment, preventative treatment, which not only includes pharmaceutical involvement, but potentially healthy habits and cognitive behavioral therapy, things can be done. Our CHAMP study, which is a study I didn't go into a lot of detail, but it's a large national study that we led, shows that you can diagnose, you can use acute treatments, and you can use healthy habits in children, but that may not be enough by itself. To make things better, though, the expectation response does add a lot of value, and that includes the pharmaceutical expectation, cognitive behavioral therapy if needed, the wait and see, and the expert effect of just seeing a specialist or just discussing the headaches and recognizing it as a problem, also by itself may have benefit. So again, I want to thank the organizers for inviting me to talk. I'm sorry I'm not able to be there with you or answer your questions, but I'm sure the panel can address any of these issues. Again, thank you for your time and have a great day.